Okay, so let's start to talk about esophageal anastomotic stenosis after esophageal atresia failure. When and how to dilate it. So this is the most frequent complication, post-operative complication in patients with esophageal atresia. The statistics are completely different. Some centers show just only 18%, some centers show up to 60%. It depends on the definition and what we say it's stenosis. And there is no clear definition of this condition. There are a lot of possible risk factors, and of course, surgical technique and tissue handling is one of the most important. But when you look to the articles, people are talking about reflux, about the tension, but nobody is talking about surgical technique. Of course, anastomosis under tension is a great risk, and also long gap esophageal atresia, but because there is a poor vascularization, a big tension, a lot of scar. Anastomotic leakage is one also of the possible risk factors, and poor tissue quality. That's interesting that sometimes we have a case that the tissue of esophageal tissue are very poor, very thin. And this is my observation that, for instance, for type B esophageal atresia, when there is upper fistula, the upper pouch is usually very short and very thin. For type A, the upper pouch, because there is no fistula, it's very thick, very dilated, and it's usually longer. Number of sutures, of course, it's very important. Usually, at my experience, it's 6 to 7, 8 suture. But I remember one case that was really very difficult. We put only 3 sutures, and there was nothing more, and it healed without any problems. Gastroesophageal reflux is probably the risk factors, but for older patients, there is more articles about eosinophilic esophagitis. And also there is a discussion about postoperative nasogastric tube that we already discussed. I don't think that this is a real risk factor. And for me, nasogastric tube, apart that we can start with early stomach feeding through the nasogastric case of any complication, because you have a connection between the upper pouch and the stomach. So if you have a leakage, you will not have to manipulate, but remember to put always the nasogastric tube with the opening at the end, so you can exchange it with, for instance, a guide wire. And also very important is experience. At our series, down in the last cases. Other possible factors, some people say that thoracoscopic repair has a higher stricture stenotic rate. So I think that it's not because of the technique, but maybe because of the experience and also because of the tension. Because with thoracoscopic more, and we can make anastomosis even under really considerable tension. So maybe this is the risk. Probably in open surgery, you couldn't do such an anastomosis that you can do with the thoracoscopic approach. So diagnosis, it's usually all based on symptoms, X-ray contrast study, and sometimes even when you have symptoms, even if you have an X-ray contrast study, you have to do endoscopy, especially for older patients that have a history of impaction with solid food of the esophagus. So for such a patient, sometimes you have to do an endoscopic study to check for the stenosis. What are indications for stenosis treatment? Of course, clinically symptomatic patient. This is the most important. So difficulty in swallowing, feeding, regurgitation, oral secretion, and solid food impaction. This is at our department, this is the most important indication. X-ray, of course, if you have like this on this X-ray that I present you, it's obvious that you have to dilate it, but sometimes If you don't have a prestenotic dilatation, it's really difficult to diagnose it. Esophageal, sorry, because it goes, okay. What are the method of treatment of stenosis? Of course, the first one is a dilatation with a rigid bougie or with a balloon. We have also adjunctive treatment like steroids, local or generally given, mitomycin C or stenting, and of course surgical incision with a knife or just resection. But to my experience, dilatation is a good standard, and we have only one case that we had to do a surgical resection of the stenosis, and dilatation is quite good. I don't have many cases with steroids usage, so it's not just only a few cases that we had to do it, but I don't know where it worked in our case. So there's a beautiful article published by European and North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. So there are guidelines for anastomotic stricture management. So it is defined as a narrowing at the level of esophageal anastomosis. That is clear. That's very clear. The severity of narrowing doesn't correlate with symptoms. There is no evidence that routine screening that some people are doing and dilatation is superior to evaluation and treatment in symptomatic patients. This is anastomotic dilatation is the first line for any patient, and it is always should be performed in general anesthesia and with tracheal intubation. And there are some potential for adjuvant treatments of recurrent strictures that include steroids, topical application of mitomycin or stents or endoscopic knife. So I presented you our results. The stenosis is about 1/4 of our patients, so it's not very, very frequent, but it's not very low. But it's, sorry, I don't have this graph to show you, but it really decreases with our experience. So we only do a rigid dilatation. I only have a few cases with balloon dilatation. We use Savary Gillard's dilators, 18 to 45 French with the hole inside, so you can use it with the soft end guide wire. It's very important. I will show you. What are the positive value of rigid dilatation? You have a direct feeling of resistance. With the experience, you can feel how hard is the step when you pass down the dilator. Also, it's very cost effective because dilators are reusable, so you can use it for many, many patients. And the negative part of this procedure is that it causes mechanical injury to the tissue, and also by compression and just mechanical tearing. So maybe it produce another one scar. So how it is managed at our department? It's wait and see approach. So there is no routine dilatation. If we have a fresh case after esophageal atresia repair, we do a contrast study on the 5th post-operative day. If the baby is doing fine, we send baby home. The baby comes back to the control usually on the 3rd month after the procedure. If it's not symptomatic, we wait even until 6 months. But if there are any problems, we just do a contrast study. And when we can see that there is any stenosis, we then do the dilatation. Of course, if the patient is symptomatic, it's always an indication. This is 1 or 2 days hospital stay. It's age dependent, whether we can do it as an outpatient procedure. Always general anesthesia with intubation. We use only flexible endoscope that is sized for patient age. always with TV screen because it gives you a lot of details, a very good magnification. So it's really very good. As I already told you, Savary Gilliard's dilatators with guide wire. We don't use X-ray routinely, only for special indication when we are in doubts whether we have a correct position of the dilatator or any complication. So in such a cases we do it. And repeated procedure we usually schedule, if it is required, 3 weeks later. Maybe it's a good idea to do it, for instance, every 1 week, but because of costs and the way that the hospital is paid by our national system, we cannot do repeated procedure every 1 or 2 weeks because it's not paid. It's paid after when the time between procedures are at least 2 weeks. Sorry, but it's the real life. So you can see this is our new equipment. So the quality of the picture is really very good, but that the camera is at the end. You can see once again, you can see a real stricture. The very narrow, the size of the endoscope is 6 millimeters, so we can see the difference. It's probably in size, it's about 2 millimeters. So if we have a picture like this, sometimes it's not so clear. It's an old equipment, but you cannot see any lumen at the stenosis. But to my experience, you always can find a way down. So sometimes it needs times. In this case, it needed almost 20-30 minutes just to go down. But finally, as you can see, I was able to go with the soft wire down. Of course, in such a case, you need to check it with the X-ray, whether you are in a correct place, whether it's not perforated. But you can see the stenosis was real. And sometimes you can go with such a guide wire. It's a little bit different. It's thicker. It's much safer than it was. And over this guide wire, we place a dilatator. And we don't do routinely a scope. We don't routinely put a scope, especially in small babies. But in this case, it was possible just to check how the dilator goes down. As you can see, it is going very, 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 very slowly. So just to have a good accommodation of the scar. So we start with the 18 size, it means 6 millimeters, and then increase it. In newborns and small babies, if it is the first dilatation, we go to 24, 27. Size, and then we increase 2 millimeters more in the next dilatators. Sometimes we have a patient, right now we are not using gastrostomy, but sometimes I have patient refer to our center with already created gastrostomy because of the stenosis or because other reason. In such a case, when we have a gastrostomy, we put a thread without end. What does it mean? That the thread is going through, usually through the nose, through the stenotic anastomosis, and goes out through the gastrostomy, and it's connected on the back of the patients. And we use it in the next procedure as a guide wire, so we don't afraid that the stenosis would be so severe that we couldn't find the way down. But it's exceptional. It is just to show you how it is. And sometimes, unfortunately, there are complications. You can see this is the case. It was, we try to dilate it without guide wire. So right now we always use a guide wire. You can see that Moses once again. So what to do in such a case? First, don't panic. Just put a nasogastric tube down, if it is possible, to the stomach. If there is a pneumothorax, of course, you have to drain. But in this case, it was just enough to just leave the nasogastric tube. Just I will show you the X-ray because it's interesting. Just a moment, it will appear in the moment. Okay, look at the X-ray. It doesn't mean that there is the liquid in the chest. This is the case, very interesting case, agenesis. So this is the heart. The baby had only one lung, left lung, and we repaired the baby with a thoracoscopic approach. And there was a mild stenosis, so we tried to dilate it, and unfortunately we perforated the esophagus, treated by conservative approach. So usually when we have, that's only few cases that we had with perforation. So in such a cases, we use only conservative treatment, always antibiotic therapy, total parenteral nutrition for 1 week at least. Oral suction on demand, I don't use any reproc tube. It's my strong belief that it shouldn't be used for esophageal atresia patient, because when you action of oral secretion, it causes the dryness of the mucosa. So it causes inflammation. So this is what we do at our department. We do oral suction on demand. Always Anastomotic tube and prophylactic chest drainage only if we have any pneumothorax on any liquid. So thank you very much for your attention. I am happy to answer your questions.